Good evening, everyone. Thank you. First of all, I want to thank Dr. Tapesh for giving me a chance to speak in this forum. The topic that is being given today is oxygen delivery devices. I hope my slides are moving. Yeah. So before we go into the delivery devices, let us just see what a little basic about oxygen, and then we'll go into the topic much more better. The transport of oxygen depends upon, if you just go about the oxygen transport, 97% is transported in combination with hemoglobin, and 3% is transported in the dissolved state in plasma. Each gram of hemoglobin actually combines with 1.39 ml of oxygen. And if you talk about a normal hemoglobin, approximately 20 ml of oxygen, when it is 100% saturated, one person with a normal hemoglobin of about 15 gram actually has about 20 ml of oxygen. And this, when it passes to the tissue, about 5 ml is lost. So with this, the reducing the saturation of oxygen about 75%. If you see, this is the oxygen cascade. That is, when you inspire oxygen, the inspired partial pressure of oxygen is about 150, that is in the atmosphere. And as it passes through the alveolar, the arterial, the capillary, the tissue, and the mitochondria, the partial pressure of oxygen can actually be seen going down. And what it reaches to the mitochondria is about 5 to 20 millimeter of mercury. When we talk about oxygen flux, it is the oxygen which is delivered from the lungs to microcirculation. That is, it refers to the delivery of oxygen to the tissue, the rate at which the oxygen is transported per unit time. So if you see, the rate that is there in the arterial side is about 1000 ml per minute, and that is being there at the venous side is about 750. The oxygen which is consumed by the tissues in between is about 250 ml per minute. So that is the lowest amount of oxygen which is required by the body. So going into these basics, we must understand if there is a deficiency of oxygen, it can lead to respiratory failure. So there are, as you know, many types of respiratory failure: type 1, type 2, type 3, and type 4. Type 1 being the hypoxic, where the failure of oxygen exchange takes place, is the most relevant in this talk. And we'll go and we'll deal a little more into it. So hypoxia can be hypoxemic hypoxia, where they can be caused by lack of oxygen in the blood. It may be just because there's a low FiO2 or hypoventilation. There could be a ventilation perfusion defect or diffusion defect. Anemic, on the other hand, is because of decreased hemoglobin level. It could be because of excessive blood loss, methemoglobinemia, iron deficiencies. Stagnant hypoxia is something which is because of capillary perfusion where it is diminished, as in the case of a decreased cardiac output, decreased heart rate, or shock condition. Histotoxic hypoxia is when there is impairment of cellular metabolism despite inadequate oxygen delivery, like in the case of the cyanide poisoning or arsenic poisoning. So if you see, oxygen therapy, mostly indications are if there is a decrease in the fractional concentration of oxygen that has been given because of a post-strate state or rebreathing, or where the consumption is increased in the case of a convulsion, thyrotoxicosis, or shivering, or when the barometric pressure itself is less, as in the case of a high altitude, or in cases where there is a alveolar ventilation is compromised, as in the case of respiratory depression or respiratory muscle paralysis. So in all these cases of hypoxic condition, not every condition is correctable. Like cases where there is a low inspired oxygen, where there is hypoventilation, or there's a diffusion disorder, like in the cases of ventilation perfusion mismatch also to an extent, it can be corrected by just giving 100% oxygen. But if you have a patient who has shunting, as in the case of a cardiac condition like a cerebral heart disease, or the patient is having pneumonia or severe pulmonary edema, one will not be able to correct it completely with 100% oxygen. So what is the goals of oxygen therapy? Basically, to maintain the tissue oxygenation while minimizing the cardiac work, correct the documented or suspected acute hypoxemia, whatever at that stage, and decrease the work of breathing. So factors which will determine which system to use will depend upon primarily patient comfort and acceptance. What is the degree of hypoxemia? What is the precision of delivery that you want? What is the level of humidification and nebulization? Minimal resistance to breathing, the economical use of oxygen. Other factors like what is the volume of mask that is being used, the tightness of fit of the mask, whether it is okay, and most effectively to buy time for definitive therapy. So oxygen delivery systems can be depend upon, if you just see the ambient pressure, it is classified into variable performance devices and fixed performance devices. When one can classify it as those which are giving positive pressure ventilation, as in the case of non-invasive and invasive. It could be by specialized technique, as in the case of ECMO, or it could be a long-term oxygen therapy. The oxygen delivery devices are largely classified into low flow or variable performance devices and a high flow or fixed performance devices. So low flow devices are those where the flow rate is less than the patient's inspiratory flow rate. And it depends very much on the peak inspiratory flow rate, reservoir. It leads to air entrainment. The FiO2 very much varies with the respiratory rate and tidal volume, and the FiO2 is not predictable. But if you see the same thing with a high flow or fixed performance device, you'll find the flow rate is more than the patient's inspiratory flow rate. It is not influenced by the RR or tidal volume, and the FiO2 is fixed and it is accurate. If you see, the low flow devices can be again classified into no capacity system, low capacity system, medium capacity system, high capacity system, and very high capacity system. I'll just 1 second. Sorry for that interruption. A low flow devices can be, as I said, can be classified as no capacity, low capacity, medium capacity systems. They basically where the low capacity system, the nasal cannula, nasal catheter, but there's no rebreathing. Low capacity is like a simple mask that is used for children. Medium capacity, where the capacity is about 100 to 250 ml. High capacity ones are those with have reservoir bag. These can be leading to partial rebreathing mass or could be a non-rebreathing mass. We'll come to it. And very high capacity systems are those like oxygen hood and oxygen tents. So this is a nasal cannula. There's the most commonly used. It delivers about 24 to 44% of oxygen. Very easy to use. The patient can talk and eat with oxygen at place. The disadvantage is it causes irritation of nasal and pharyngeal mucosa. It cannot be used with nasal obstruction. It can cause drying of mucous membrane. The nasal catheter with a normal respiratory rate and depth of breathing. With each liter per minute of nasal oxygen, the FiO2 increases by 4%. So this is how we calculate. If you have given 1 liter per minute, the FiO2 that is reaches 0.24. With 2 liters, with 3 liters, and as it progresses to 6 liters, the FiO2 reaches about 0.44. Nasopharyngeal catheter is like a suction catheter with multiple openings. The size is about 8 to 15 French. It is inserted upon the fold of soft palate, and they need to be changed from nostril to another. About 40% of FiO2 can be delivered in this. The disadvantage is it can cause nasal irritation. So this is how a nasopharyngeal catheter can be seen with multiple holes in it. This is a simple face mask. A simple face mask usually has an exhalation port and oxygen source connected to it. The flow rate, as you can see, is depend upon 5 to 6 liters. It starts from 0.4 to about 0.6 is the FiO2 that can be reached with a simple face mask. The head has to be held with an elastic band. There's a metal clip on it, as you can see here, a metal clip, which is placed on the bridge of the nose, and thereby it gives a comfortable fit. It is useful when increased delivery of oxygen is required for a shorter period. The merit being higher oxygen concentration can be given, but the problem is a tight seal is required and there can be rebreathing. It can interfere with further airway care. It can be uncomfortable for the patient and can cause skin breakdown. A partial rebreather mask. A partial rebreather mask is something which has a reservoir wire that needs to be inflated both during inspiration and expiration, and it collects part of the patient's exhaled air, and the remaining exits through the vent. I'll show you the diagram also. We used to deliver 100% oxygen concentration till up to 80%, where the flow at least has to be 6 liters per minute to prevent any rebreathing. Now, this is a partial rebreather mask, and there is no one-way valve in it. But this is another mask, which is a non-rebreather mask. Now, there's a one-way valve. So how does it act? It is similar to a partial rebreather mask, except that 2 one-way valves are there and they prevent the conservation of exhaled air. The valve over the exhalation port, it prevents the air entrainment and expired air is deposited outside. And here the flow should be at least 8 to 15 liters per minute. If the bag does not completely collapse, then a highest concentration of 95 to 100% is being provided through this mask. So let us see. I'll just show you how it is. Once the oxygen source is connected, the oxygen which is entering will enter the reservoir bag, fill the bag, and this is what the patient actually breathes. When the patient exhales, because of the one-way valve, the gas doesn't, I mean, the carbon dioxide cannot actually enter the reservoir bag. It has to be exhaled outside. So that's why with every inspiration, the amount of oxygen that goes and collects in the reservoir actually increases. And thereby the patient actually gets about 85 to 100% of oxygen. And there is less chances of rebreathing because the exhaled air doesn't actually come inside this reservoir bag. So if you see the advantages, it delivers highest possible oxygen concentration. It is suitable for spontaneous breathing patient with severe hypoxemia. The disadvantages are there. It is not recommended for long-term therapy, and there can be carbon dioxide buildup, and it can be uncomfortable for a long period if you use it. So these are other devices. There was an oxygen tent. This is how previously many years before oxygen is delivered. Even now, oxygen hood are used, especially for children. And these hoods were also had become very popular during the COVID period, where it becomes very comfortable using the hood to deliver oxygen to the patient. Bag and mask, bag wire mask. Here, this is it has a face mask, an expiratory valve. There is a PEEP valve, which is there, a self-inflating bag, and this it can be connected to a reservoir. Now, this reservoir can actually increase the FiO2 by connecting to a reservoir, just like a non-rebreather mask. So how does it help? It can be used both during spontaneous and controlled ventilation. The concentration can be without reservoir, about a FiO2 of 30 to 50% can be reached, and with reservoir, about 80 to 100% can be reached. It can deliver about 100% oxygen if the reservoir is as large as the bag volume, and the oxygen flow rate is if it is more than the minute volume. The problem is the rescue hand is always engaged. So here, this is the pop-off valve. The mechanism in this case is that the patient actually, when the oxygen source is connected, and again, the bag can get filled up with oxygen as in the a non-rebreather mask. The oxygen first can go here. It can actually go to the patient end. And when the patient inhales, the patient gets full FIR to 100%. If the reservoir bag is connected, can increase the percentage of oxygen. And the exhalation is through this valve. So there's a PEEP valve also, which can be attached to it. It can give a PEEP during exhalation. At the same time, the POP valve will actually help in exhalation, or the POP valve can help in exhalation of the expired air. Then we come on to the fixed performance high flow system. These system where the gas flow is sufficient to meet the inspirated demand, high flow is being delivered. It provides consistent and predictable FiO2 regardless of whatever the patient's inspirated demands. It plays on principle of air entrainment and gaseous jet mixing. Advantage being that is cheap and comfortable. So the factors which govern in this fixed performance systems are the ventilated pattern of the patient, the size of the oxygen reservoir, and the flow. The examples are the nasal flow oxygen, the air entrainment mask, the venturi mask, the mechanical ventilators, NIV, and hyperbaric oxygen chamber. So coming on to the venturi mask. So this is a venturi mask, and these are the jet adapters which are connected to it. So you can see that it has the flow of 3 to 15%. So every adapter has a flow which is written on it, and the FiO2 that can be reached with different liters. So venturi mask, basically what happens there is the room air dilutes oxygen entering the tubing to a certain concentration. It applies in the Bernoulli's principle. The amount of air drawn in is determined by the size of the orifice. And each color code applies to precise oxygen concentration in a specific liter flow. So the oxygen delivered can be from 24% to 50% at a flow rate of 4 to 15 liters per minute. A constant flow of room air is blended with a fixed concentration of oxygen. So this is how it works. You will find that there is an oxygen source which is connected to an adapter. And as the oxygen is going through this adapter, because of the high flow, there is a negative pressure which is created, and that entrains air from the atmosphere. So There's a blending which is taking place, and thereby the patient gets a fixed percentage of oxygen. Now, this fixed percentage depends upon what is the size of orifice which is there on the jet adapter. So that is why they are color coded, and that also tells you that at what flow, if you maintain at what flow, you know that this much percentage of oxygen is delivered through this color coded venturi mask. So if it is 4 to 6 liters, and if you use a white valve coded venturi valve coded jet adapter, you will be able to attain a FiO2 of at least 28%. Then there's something known as tracheostomy collar. Now, this is indicated for closed chronic oxygen therapy, and it is inserted directly into the trachea. The oxygen flow rate is about 8 to 10 liters. It provides saturated FiO2. It is very comfortable to use. Now we come to the normal and the most commonly used non-invasive ventilation, and the positive pressure ventilations, where you find non-invasive and invasive ventilation. The non-invasive ventilation basically means that there is a delivery of mechanical ventilation to the lungs using techniques that do not require endotracheal intubation. Here, positive pressure is produced and it is provided, and that improves the alveolar ventilation. It decreases the carbon dioxide accumulation. It helps in alveolar recruitment and thereby intrinsic PEEP. It decreases the work of breathing. It decreases the afterload to heart. So the types of NIV and its indications, if you see, the commonly known as BiPAP machine is one type of NIV. CPAP, non-invasive positive pressure ventilation, which we give through the ventilators. So the prerequisite for a non-invasive ventilator is, if it is done in, it is not the home BiPAP that we are talking about. We're talking about the NIV that we give at the ICUs. The prerequisite will be a walled oxygen. And when we talk about NIV, what we're talking is the NIV that we are given in the ICU. So it requires a walled oxygen, which contains a high flow. It requires an interface like a mask, which is suitable for the patient. There should be desired PEEP, which is to be provided through the NIV, and that can be attained by a resistor, which can be kept at the expiratory limb. The tubing should be short and wider. There should be a humidifier. There should be provision of jet nebulizer that could be given for nebulization. It should have a backup battery and a backup apnea. That is, if the patient is not breathing, there should be a provision to give a backup apnea, respiratory rate. There are circuits which are specific for non-invasive ventilation, which could be a single limb circuit or it could be a double limb circuit. So the single limb circuits are those where we should find that it is connected to a mask, and this mask is basically the one which is connecting, and it is exhaling through the port. Excuse me, just 1 second, please. Sorry, I'm getting a call. I have to take the call. Sorry, that was a call from the ICU. So going back, the circuits that are used on an IV can be a single limb circuit or it could be a dual limb circuit. So this is a dual limb circuit. So a single limb circuit, the mass which is connected to a single limb circuit should have an exhalation port. So it can be on the mass itself. Sometimes they provide in the mass, or it could be a exhalation valve which is provided along with it, and this is very much required when you have a single limb circuit. But if it is a double limb circuit which is connected to the ventilator, usually the mask doesn't have an exhalation port and it is being taken care by the ventilator itself. Before we go on to the settings of an IV and to understand an IV, we have to just go through certain terms like, so before we go into it, let us see the terms which are frequently used in an IV. Like this is a breath cycle where there is inspiration and there's an expiration. So EPAP, that is expiratory positive airway pressure, which is also the positive and expiratory pressure, is actually a pressure which is above the baseline. So in NIV, we usually set two levels, like in a BiPAP. When we say BiPAP, there's two sets of pressures, an EPAP and an IPAP. Expiratory pressure, positive airway pressure, and inspiratory positive airway pressure. So expiratory airway positive airway pressure is actually the peak. And from here, when the patient starts breathing, he attains an inspiratory positive airway pressure. The difference between this is what is known as the pressure support. And this pressure support is the one which determines how much of tidal volume is delivered. Now, once the IPAP is reached, the patient will keep on inspiring and then he will cycle. That is, it will convert from an inspiration to expiration. So the time that it takes for the EPAP to reach to the IPAP is what is known as rise time. So when we talk about CPAP, that is continuous positive airway pressure, it is nothing but EPAP, that is end expiratory positive airway pressure, a continuous pressure which has been given. And this EPAP to IPAP rise time, that is the time that it takes to reach from EPAP to IPAP, is the rise time. And if you talk about what is TI on an NIV, it is the time that is taken, inspiratory time that is taken and that has been set. Now, there are two other terms, TI minimum and TI maximum. So what is TI minimum? It is a minimum inspiratory time which is allowed on NIV, and TI maximum is the maximum inspiratory time which is allowed on NIV. So these are the usual terms that one must be familiar with. Minimum inspiratory time, that after this time, the cycling will start. And the maximum is only till this time there can be IPAP maintained. After this, anyway, the cycling has to start. Maximum allowable inspiratory time and minimum allowed inspiratory time. So common settings that are done in an IV are the EPAP, the IPAP, a backup rate is set, the trigger sensitivity, inspiratory time, that is TI minimum and TI maximum, cycle sensitivity, and rise time. Common ventilator modes are CPAP, the spontaneous mode, the spontaneous timed mode, and the PAC. So let us see what are these. Before that, we'll just go through again what I said to reaffirm that IPAP is a pressure support. It provides a pressure support, increases the tidal volume, oxygenation. It decreases the water breathing, respiratory rate. It improves the alveolar ventilation and decreases carbon dioxide. EPAP, which I also said as that is a CPAP, it provides PEEP, prevents carbon dioxide rebreathing. It decreases the effects of intrinsic PEEP, and it improves oxygenation and decreases the work of breathing. Now, if you see here, this is the trigger sensitivity. So what is trigger sensitivity? Usually what we keep is a medium trigger sensitivity. So when we say trigger sensitivity is high, actually what it means is there's a low flow that is set. So if the patient is very apneic and respiratory distress, you said we require a high flow. That means your trigger sensitivity is kept very low. So trigger sensitivity is low, the flow is actually required is very high. And if it is a very high sensitivity, that means sensitivity is high, it is quick to trigger. It just means that it is very quick to trigger. So a low flow is enough in that case. Now, what is a control pressure mode? So constant pressure mode, constant pressure, it was what is usually given between 4 to 12 centimeters of water is delivered. So if this is what we see, that is it is a pressure mode. So if you see, this is the constant pressure, which is usually between 4 and 12 centimeters delivered throughout inspiration and expiration. It is all the patient effort. The trigger is done by the patient. Here the RR, the flow, the tidal volume, everything depends upon the patient's breathing effort. It's just that it is above the baseline pressure. A spontaneous mode, in the spontaneous mode, again, the patient initiates the breath and he initiates the inspiration as well as the expiration. So the trigger is by the patient and the cycle is within the TI max and TI minimum. That is, it has to be within the minimum inspiratory time allowed and the maximum inspiratory time allowed. So it can go to the maximum, but not more than the T max. In a spontaneous time mode, the ventilator will actually, the patient is breathing. Apart from the patient, the ventilator also will deliver a breath if the RR falls below the backup rate. So here the trigger is by the patient, and trigger can also be by the device if the backup rate falls into. And the cycling is within the TI and Tmax. It cannot be more than the TI Tmax. Now in a pressure assist control mode, the ventilator is triggered by the spontaneous breathing of the patient. And again, if the inspiratory rate falls back, the ventilator will provide a breath. So the trigger is by the patient as well as by the device. But the cycling will end at TI. In the sense, the cycling is according to the inspiratory time. So whatever time you have kept at that time, the cycling will occur. In a time mode, there is nothing like patient triggered. It is everything done by the ventilator. So the respiratory rate and the inspiratory time is regardless of patient effort. So the trigger and cycling is by the ventilator. So what is the indications of NIV? If you have to give an NIV, the patient has to be cooperative. The prerequisites are that he should have a functional intact upper airway, that it is not in need of any airway protection to manage secretion, and the patient should be hemodynamically stable. The settings, how do you start it? You should actually start it in a low setting and increase it gradually to avoid any increase in anxiety. Hold gently on the patient's face. Mask has to be held gently. Start with 10 centimeter of water, inspiratory pressure support, and 5 centimeter of expiratory pressure support. The pressures are adjusted as required to achieve common endpoints. So the respiratory rate can be below 25. You have to reach, if the patient is tachypneic, he has to come down to a normal respiratory rate, get adequate, produce adequate tidal volume, and the peak pressure should also be less. Apart from this, if you do an ABG and you see that there is a requirement, then you may increase IPAP by 2 centimeter if there is persistent hypercapnia. So increase in IPAP will actually wash off the carbon dioxide because the tidal volume delivered will actually increase. But if there is a persistent hypoxemia, then you may have to increase both IPAP and EPAP by 2 centimeters. The maximum that IPAP should reach is about 20-25 centimeter. Otherwise, it will increase the pressure of the esophageal pressure, go above the esophageal pressure, and there can be gastric distension and patient discomfort. EPAP is mostly till 8 to 10, maximum, very rarely we can go up to 15, but it can also be increased according to the number of missed breaths that are there. The FI2 has to be adjusted so that you get a acceptable pulse oximetry value, and a backup rate has to be set at 12 to 16 breaths per minute. So when you monitor, you obviously the interface can be a full face mask, the nasal mask, or a nasal pillow mask. Whatever it is, it should be of the correct size according to the patient and according to the comfort of the patient. One may use standard ventilators for a NIV, but watch for gastric distension. Sorry. The heart rate and the respiratory rate should decrease. Patient should be more comfortable. Oxygenation should improve. There should be improvement in the mental status, and the arterial blood gas pH should improve. So monitor the patient closely for any decompensation and any need for intubation for 2 to 4 hours. The advantage is that it improves the lung function. There can be short ICU stay. It can prevent the need for intubation. It can prevent airway collapse and lower the fatigue, respiratory muscle, and reduce the work of breathing. And obviously, more effective delivery of bronchodilators. But when you cannot give an IV is if the patient has a low GCS, has acute respiratory spasm, hemodynamic instability, pneumothorax, head injury, causing deterioration in consciousness, high risk of aspiration, or there's a GI bleed, active bleed, severe bleed, or the patient is not able to clear secretions. When does it fail? If the patient is asynchrony with a NIV, if there's increased secretions and there's a persistent high respiratory drive, then we are very sure that this is not going to have any effect. If there is intolerance, limitation of positive pressure, patient is not able to feed, hemodynamic instability, arrhythmias occur. The complications are that nasal congestion, dryness about, patient can even aspirate, and hence constant monitoring on NIV is very much required. Now we all go on to another device which has become very popular and which is very useful in the critical care setting, in an acute emergency setting, HFNC. Normally in health, quiet breathing usually generates a gas flow of 15 liters per minute, but when we exercise or if the patient is in respiratory distress, the flow rates required may reach up to 120-150 liters. And you can achieve it for shorter periods, but you cannot keep it sustained, and it can associate it with fatigue. Apart from that, warmed and humidified air, when it passes through upper airway, it gets warmed and humidified about 80 to 90%. But when inhalation of air is through mouth, as in the case of patient who's in respiratory distress, it reduces the maximum achievable relative immunity to 70%. So that's why when this high flow nasal oxygen cannula, actually nasal oxygen became very popular. This machine basically actually contains a motor which can actually produce high flow of oxygen. So this flow of oxygen which is produced, which can reach up to 60 liters per minute, one can deliver oxygen straight away by attaching the oxygen to the machine, or by using a blender device, air oxygen blender device. So once this gas enters there's an active humidifier which actually warms the gas according to the at least to the body temperature 35 to 37 degrees Celsius, and then it passes through a corrugated tube. So this corrugated tube is actually embedded with heated wire. The heated wire is inside it. So this warm gas actually passes through the circuit and the temperature is maintained. So what actually the patient gets is 100% of FiO2 oxygen, 100% oxygen, which is humidified at a temperature which is 35 to 37 degrees Celsius, apart from with a flow of 60 liters per minute, which is a requirement in a case of distress. So this is actually the oxygen source which has been connected. So there's a flow meter which will show the oxygen which is actually connected, and oxygen is being delivered through the device. HFNC, there is breath and flow dependent airway pressure throughout a respiratory cycle. It promotes slow breathing as well as rebreathing. The room air entrainment is actually minimized, reducing the oxygen and humidity dilution. It helps in clearance of expired air in the upper airway because a gush of air actually gets inside the high flow which is taking place. So there it acts as a reservoir. So whatever carbon dioxide is there, it is actually cleared and the whole airway is filled with 100% of oxygen. So it helps in clearance of expired air in the upper airway. It decreases rebreathing and increases alveolar ventilation. For every 10 liter per minute flow, there is a PEEP generation of about 1 millimeter mercury, especially when the patient has a closed mouth breathing. And hence, it actually helps alveolar recruitment. So the advantages is the FiO2 values delivered can be from 0.21%, can reach till 100%. There is reduction in anatomical dead space, nitrogen carbon dioxide washout would be there. It reduces the work of breathing. The PEEP generation helps in lung recruitment. There's delivery of warm and humidified gases. Patient comfort is very much in cases of HFNC with respect if you compare an NIV. And there's also provision to give through tracheostomy. So this is actually a provision how tracheostomy, this can be connected to a tracheostomy tube, and the same device can be used to deliver high percentage of oxygen, high flow oxygen. So how do you set it up? There is a switch button. We have to press the switch button for about 5 seconds. And after switch, you'll be able to see certain values which are coming up. And each value will actually pulse until it reaches a set point. So when you press this, you can keep on changing the thing, the temperature and the FI and the flow can actually be changed. Once you can see the blinking on the monitor on this screen, then you can press on the buttons, it will get selected. Once it is selected, you can a padlock symbol appears and the lock is replaced with an arrow. Now you can use up and down buttons to set the value. And once the gas flow rate and temperature is set, you can press on the ready to use symbol. So this is how the initiation should be. Initiation, you should start at 30 to 40 liters per minute and then increase to meet the patient's demand. Set a temperature at 37 degrees Celsius and increase FiO2 slowly till it decrease. There's a decrease in respiratory rate or there's a desired SpO2 range. And for weaning, one must first try to decrease FiO2 by 5 to 10% and reassess every 1 to 2 hours, aiming for a saturation of more than 92%. And then come down to the flow rate by 5%, reassess after 1 to 2 hours. And consider weaning when the flow rate, by doing all this, the flow rate has come down to 25 liters per minute and the FiO2 has decreased less than 40% requirement. And yes, the patient should have decreased workup breathing. As reiterated, it provides a heated humidification of inhaled gases, so the secretions are less. There's a washout of upper airway, hence the dead space is decreased. There is a high nasal inspiratory flow, since the nasal resistance decreases. The positive airway pressure is provided, and thereby recruitment of electric lung, and there is decrease in entrainment of ambient pressure. So the oxygenation is also increased. Indications are usually an acute hypoxemic respiratory failure, especially in post-extubation and ICU. You can use it as a bridging therapy. Post-extubation following surgery, pre and peri-oxygenation during intubation, especially in bronchoscopy, and chronic respiratory failures and decompensated heart failure, when you really can take time to avoid intubation, and at the same time, try giving quality oxygen with a high flow to the patient. The monitoring is usually, one is to see the clinical improvement of the patient. The patient is comfortable, patient is breathing normally, the workup breathing is reduced, the respiratory rate is reduced, the heart rate is reduced, the blood pressure is normalized, there's no hemodynamic instability. ROX index is a second monitoring parameter that can be used. It is nothing but SpO2 minus FiO2 by the respiratory rate. So if it is more than 4.33 at 24 hours, or it is more than 3.7 at 6 hours, it predicts success of using and you can continue using it. So this is in nutshell a small comparison between HFNC and NIV. The large bore nasal cannula is used here. The mass interface is used in NIV. It reduces room air entrainment, and here the flow rate is set, and here pressures are set. Less pressure produced, but this provides greater ventilatory support. We all know about ECMO. This is another form in which oxygenation can be done in a hypoxic patient. I'm not going detail into it. Hyperbaric oxygen therapy is another way in which oxygen can be delivered. It can be used for various conditions, as written here. And dissolved oxygen. So basically what is actually happening is hyperbaric oxygen therapy increases the dissolved oxygen in the plasma. So if you see when you breathe air and at a partial pressure of oxygen of 100 millimeter mercury, what is there is 0.3 ml per 100 ml of blood. Every 100 ml of blood contains 0.3 ml of oxygen. But the same breathing, if it takes at 3 atmosphere pressure, that is at a hyperbaric oxygen, the amount of oxygen in 100 ml of blood actually increases to 5.4 ml. So that is the basis of using hyperbaric oxygen therapy, and is found to be useful in treating many conditions. But when we have talked about oxygen therapy, we should also know a little bit about what is the complication of oxygen therapy, wherein we can see that the oxygen toxicity can produce reactive oxygen species. There can be hypoxic pulmonary vasoconstriction. Systemic vascular resistance can increase because of hypoxia, and thereby there can be coronary renal cerebral blood flow decrease. There can be depression of ventilation, retinopathy of prematurity, and absorption of electrolysis, especially if we give 100% oxygen for more than 12 hours, 75% more than 24 hours, and 50% more than 36 hours. So the adverse effects of oxygen can be, if you for 12 hours, if you're exposed to oxygen, there can be tracheal bronchitis, substernal chest pain. If there's 12 to 24 hours, there can be a decrease in vital capacity. If 25 to 30 hours, there can be a decrease in lung compliance and increase in partial alveolar and oxygen pressure difference. And if you give it for 72 hours, there can be a decrease in diffusion capacity also. So this was regarding the oxygen delivery devices in concise. I know I had been a little faster, but if there's any questions, I'm happy to take it. As I don't find any more questions, thank you. Thank you for giving me this opportunity. And